Okay. So TW is a 60-year-old gentleman. His risk factors for ACS include hypertension, hyperlipidemia, and diabetes mellitus. On May 2013, he was admitted to our department with acute inferior wall ST elevation MI, and here you can see his admission ECG, very clear. The diagnosis is there. He was urgently taken to the cath lab, and as you can see here, he had a normal left system, but as can be expected, he had occluded prox RCA. Paul, you were operating on him. You probably remember him. And the RCL was nicely reopened. Actually, yeah. So the patient was sent home with this ECG showing typical picture of recent inferior wall MI, and the medication was as written down on the slide, the discharge medication. Beside the DM, the medication for the diabetic was aspirin in a dose of 100 milligrams, prasugrel in a dose of 60 milligrams, atorvastatin, and ramipril. He was okay until a month ago, 11 months after first myocardial infarction, when he readmitted to our department for acute non-ST elevation MI. You can see the ECG here, a typical ECG of diffuse ischemia with diffuse ST depression, slight ST elevation on V1 and AVR. The troponin went up to 9 microgram per liter, or microgram percent. On the same evening, he was admitted in the afternoon, late afternoon. An echo study was done. The echo showed reduction in the EF for 45 to 35 due to new anterior apical akinesis. We were able to compare it to the previous per-discharge ECG, and no significant valvular disease was noted. The next morning, the patient was taken once again to the cath lab because there was, first of all, it's good to do this, and the patient during the night has slight pain, and this was the picture. As you can see, within 11 months, new lesion, critical lesion in the LAD involving both the diagonal and the septal branch. Okay, you can appreciate it from here. And the RCA was totally occluded, and the decision was to send to the patient for CABG. And here I have a few questions for you, the panel members. And I'll start with asking how common is dual antiplatelet failure among patients presenting with ACS? And Professor Angiolillo mentioned the need how to treat a patient on clopidogrel failure. Here we are actually dealing with Efian failure, but I expand my question to how common is dual antiplatelet failure. And the second question is, what is the clinical significance of dual antiplatelet failure? Any comments?
Okay. Well, so a few comments. So to address the first thing, what is the prevalence of that failure? I think you should be commended for presenting such a case at a Lilly sponsored session, because what this indicates is not that because a patient is on one of the novel agents, you're immune from any type of ischemic recurrence. And what this teaches us is that clinical failure is not the same as for example, resistance to an antiplatelet agent. And because there are many other pathways leading to an ACS where platelets just represent one of them. We believe it's one of the most important, but there are definitely others. With regards to the prevalence, the trial data show that even with the new agents, we're around 10%. This can vary according to patient population. But what I think is important is that these do remain a very high-risk patient population, because if you're having a recurrent event despite maximal therapy, these patients do have a worse prognosis. The only thing that I would say in regards to this specific case, and I may be wrong, I noticed that he was not on a beta blocker.
No, he wasn't.
He wasn't. Okay.
Correct, he wasn't. So actually, Ariel, anything to note? Okay. So those are the results from the ACS 2013. This is periodic. In the past it was biannual. Now it's every 3 years. National survey of ACS in Israel. And those are the results from April 2013. As Dominique, you can see, it's not far away from 10%. About 13-14% of the patients were on clopidogrel while arriving to one of the units in Israel with ACS. Very few patients like this patient was on Efient or ticagrelor at the time, but eventually, if we summarize the numbers, more than 15%, and this is a major problem, came on P2Y12 blockers and can be clinically, on a clinical basis, can be defined as P2Y12 blocker failure. As you said, it's not a very favorable case to present in a satellite by Lilly, but what might be the reason for the failure? Yeah, when we are speaking about drug failure, it doesn't mean that it doesn't work. And I can think about potentially two major explanations. One, that the drug is not working, and we know very well the issue of drug resistance. But at the same time, it might be not failure of the drug, but just progression, maybe failure of statins and a failure of us to reduce the statins, or mainly failure to block the progression of coronary disease, which we know it's a progressive disease. And here you can see the light transmitted aggregometry that we done on this patient the next morning while the patient on Efient. And as you can see here, the Efient works very well. The ADP-induced platelet aggregation is the maximal ADP-induced platelet aggregation is 30, so the patient is not resistant to Efient. The Efient is working very nice. And despite this, and you mentioned the issue of recurrent event and the importance of continuing medication, and he's, by the way, responding very nice to arachidonic acid. Yesterday evening, dealing with the significance of any P2Y12 blocker, yesterday evening, Dr. Asher from our group presented an abstract, again from the ACS, from the national survey, looking what is the significance of patient being on clopidogrel, actually clopidogrel failure with ACS. And you see here, this is from the 2008 and 2010 survey. You can see here that the rate of clopidogrel failure was a bit lower than the 15 that I'm speaking about in the 2013 survey. And you can see here very nicely that the patient, the clopidogrel failure patient, is much sicker. They are older, more likely to be to suffer from diabetes, to have chronic renal failure, and not surprisingly, more likely to have a history of prior cardiovascular disease. Interestingly, they were significantly less likely to present with ST elevation, like the present case. And when we followed the patient for 30 days, as you can see, appreciate from this slide, there were 2.6 times more likely to sustain stent thrombosis during the next coming 30 days. And that was an independent finding of the differences in the baseline characteristics. And as you can see here, the MACE, which comprised death, Re-MI, stroke, stent thrombosis, and Re-ACS, was also significantly higher among those patients. But as you saw in the presentation by Dr. Angelillo, if we follow the patient, so it's not nice to have failure, but if the patient is arriving with ischemic event while on clopidogrel or prasugrel, it's better to be on prasugrel, because when we follow those patients, we see that the mortality among those who sustained the event while on prasugrel was more than 50% lower than in patient on clopidogrel. So our patient was, as I mentioned, on prasugrel, and sure enough, he survived. He survived to the decision to undergo operation. And my next question to you, my friends on the panel, is when should the CABG be performed, and would that be different if ticagrelor, if we were dealing with ticagrelor treated patients?
So I think these are relevant questions, and I'll do my best to respond. One of my hobbies has also been looking at bridging strategies, et cetera, et cetera. So let me give you my view on this. So first of all, when should the CABG be performed? That was a very tight LAD lesion, a patient with an occluded right. And so this is a patient which, in my opinion, should undergo surgery during the hospitalization. I would not feel comfortable sending that patient home, my personal opinion. We have the issue that the patient is on prasugrel, and the patient does have a high risk of bleeding by definition if the patient goes to surgery within 7 days. So would the timing be different if the patient would be on ticagrelor? It would probably be just a 2-day difference. You still need to wait 5 days with ticagrelor. Actually, the European label says 7 days. I know the guidelines say something around 3 to 5, but I think it's fair to say 5 days. So you may have, the only advantage with ticagrelor, you have a 2 extra day window. The question is, do you bridge this patient to surgery or not? And there's not a clear answer to this. I think actually the fact that he is on prasugrel is giving him protection. If looking at this coronary anatomy, it's a non-STEMI, high-risk LAD lesion with an occluded right. I personally would bridge this patient with a small molecule 2B3 inhibitor after discontinuing prasugrel for 2 to 3 days, and then bridge with a small molecule until 12 hours prior to surgery. If we would have cangrelor, that would be another option. But I think in this patient, it's a reasonable strategy, also because if that LAD goes down with an occluded right,
the patient is going
this
down.
patient will die. So that's my strategy.
Thanks. Again?
We are at our center at Rambam. We sometimes measure the verify now, and based on the measurements, we decide whether to start or not to be antagonist. And certainly before the operation, we measure to see that we are on the right area.
I think I saw Eli. Here's Eli. Eli has a very nice data following the patient using the verify now, adjusting or defining the right time for operation. So that's really one way to go.
Yeah, that's a very good point. We don't do that in our practice because the way platelet function testing is embedded in our practice, where we can only use it for research. But the most recent surgical guidelines have now provided a class 2A recommendation, although it's not based on outcomes data, to evaluate timing to surgery based on platelet function testing. And so definitely that's a very reasonable strategy.
So unfortunately, as I mentioned, the patient had pain while going to the cath lab. So the option to wait was not really an option. So I'll tell you what our perspective in Tel Hashomer, what we are doing. Pretty much based on the data coming from the recovery study, which is dealing with recovery of platelet reactivity after cessation or stopping of different antiplatelet therapy. So the recovery study, which included almost 60 patients with stable coronary disease, were randomized either to prasugrel or clopidogrel on top of aspirin. And both prasugrel and clopidogrel was stopped after 7 days of therapy, and thereafter the platelet reactivity was checked, was measured every day for 10 days. And this is the results of the recovery study. Quite complicated slide, but let me lead you in this slide. On the vertical axis, we see the percentage of patients with recovered platelet reactivity, and on the x-axis, you can see the days elapsed from stopping medication. The result for clopidogrel is in light blue, and for prasugrel in green. And we can see that, I think that at least in Israel, I think many places or all places, we feel quite safe to operate a patient on clopidogrel. So if we use it as a reference point, we see that after 5 days of cessation, of stopping of prasugrel, we are pretty much at the same situation from the platelets perspective, even in a better place. And why we feel safe to operate on clopidogrel, and we, in case if there is no other option because the patient continue to have ongoing ischemia, is why do we feel safe to operate in this situation of 30% or 40% recovered platelets? And the answer is that, as you all know and mentioned in the lecture by Dominique, is that both clopidogrel and Efient are both the thiopnoperidines, and they link to the bind to the receptor irreversibly, which means that we have a very good antidote, namely platelets. So we can overcome, we know that we can overcome the effect of clopidogrel. Does it work with Efient? The answer is yes. We need much more platelets, units of platelets, but still it works. This is a slide from the presentation in the ACC by Valentin Fuster from the group of Valentin Fuster. And we can see here that this is a kind of clinical ex vivo study. The patient was loaded, the patients were loaded with prasugrel. They wait for 24 hours, and then they ex vivo in the lab diluted the blood of the patient with platelets. More or less what we are doing when we take such a patient to the cath lab, when we give 8, 10 units of platelets intravenously. And by diluting 80% of the platelets volume, corresponding to about 10 to 15 units of platelet, that's a lot, but we can see here that by doing this, we can recover platelets reactivity more or less to the normal level. So, or at least to Plavis level. So with prasugrel, although it takes time, we have an effective way to overcome during the operation the antiplatelet effect. What about ticagrelor? Ticagrelor is allegedly reversible medication, but I agree that's not exactly reversible medication. The binding is reversible, but allegedly it's reversible, but it's not so. If we stop, this is from the on-time from the offset study. As you can see here, when we stop taking prasugrel, when patients stop taking prasugrel, it takes 48 hours to 72 hours to be in this place where we apparently feels well. Now the level of inhibition of platelets is like Plavix, but it's not like prasugrel, because ticagrelor is irreversibly bind to the receptor. Therefore, in this case, I'm not so sure that we have antiplatelet therapy or antiplatelet antidote. And therefore, if we want to be on a very safe ground, we have to wait for 5 days. This is my opinion. So if you ask me, what do I prefer? So I prefer to operate on prasugrel, having platelets on my hand, than to operate here when I don't know if I really have antidote to this amount of antiplatelet effect. The last question that I would like to ask the panelists is what should be the antiplatelet that's used after CABG? What do you know about it?
Well, before answering this question, I wanted to add a comment on your prior regarding the platelet transfusion, because it is a very relevant topic. And I think that you highly indicated this. I just want to remind, for example, even in the package insert of Prasero, it's clearly indicated that you can provide platelets with the recommendation that you give the transfusion 6 hours after a loading dose or 4 hours after the maintenance dose, because you want to make sure that there aren't any active metabolites which are circulating. So that's a huge advantage. With ticagrelor, in addition to the concept of reversible binding, there is no data. And from a biological standpoint, if we know that the half-life is around 10 to 12 hours, so that's still circulating a lot. And so if you give a platelet transfusion within that time frame, which is a lot longer than with Prasero, you're definitely making the transfusion not efficacious, because the drug's going to bind to it. So I would like to see studies to that extent. With regards to what to do in this specific patient after surgery, I don't have a clear answer, because we know that this cohort of patients in the trial actually had a mortality benefit,
right.
The cabbage patient.
Yeah.
And so, but we do know from the trial that these patients did not continue afterwards. And so it's not, I don't have a clear answer. I think that if you believe this is a high-risk patient, anecdotally you can use Prasero. If you look at the Plato data, this would be a patient that could have continued with ticagrelor, and there was a benefit there as well. Or you could have continued with clopidogrel. I think all three are potential options.
No, of course, I'm not going to treat this patient with P2A12 blockers at all. I will wait for 3 days.
But after surgery.
Hoping to be in a situation where I'm feeling safe, like with clopidogrel, and then I will operate on him using platelets. I would say at least 8 units. I will transfuse at least 8 units and see what's happened during the operation. So the last question is aiming at this point that you mentioned, is the benefit of continuing P2Y12 blockers, the novel P2Y12 blockers, and by asking what antiplatelet should be used after cabbage. I'm pointing at this subject. Ariel, anything? What?
Well, I truly, if this was my patient, I would continue with Plavix, and that's enough. Or
so continue
although
with
the
Plavix.
FENT was, we showed clinically in the lab that it's okay.
So it's not even continuing with Plavix is not the usual thing, because usually after operation we continue with aspirin, period.
Yes.
So,
this is what we're saying, that maybe aspirin alone.
So probably I would do the same. I will go with dual antiplatelet therapy and be very careful. But at least the fact is that both with ticagrelor as well as with Efient, with Prasero, among the TIMI-38, patients who were continue on Prasero as compared to clopidogrel had a huge mortality benefit of more than 50%. And this is at least subject to consider. I don't think that anyone is now deliberately continue, but I think that in the next coming years we have to look into this issue, and probably any kind of dual antiplatelet therapy would be the best antiplatelet regimen after coronary bypass. Okay, thank you very much. And now, Ariel, we will going to switch.